So a lot of things have actually been covered, and you will see some repetition of some of the things that have been discussed by Dr. Zamora and Dr. Calhoun. But repetition is good because it helps cement some of the concepts that we are trying to teach and things that we can take from this session. So let's get started on this. We're going to talk about the simple shunt lesions. And the simple shunt lesions are the atrial septal defect, the ventricular septal defects, patent ductus arteriosus, and all this pulmonary venous connections. Okay. So let's start with the question: which of the following is not true for simple shunt lesions? Okay. ESD causes left to right shunt and right atrial and right ventricular enlargement. ESD causes left to right shunt and right atrial and right ventricular enlargement. Partial anomalous pulmonary venous connection causes left to right shunt and causes right atrial and right ventricular enlargement. Patent ductus arteriosus causes left to right shunt and causes left atrial and left ventricular enlargement. You guys sign? So the question is not true. Okay, so majority of the people got it right. There were a few people who were confused about what shunts causes what chamber enlargement. So let's go over these shunts one by one. And so atrial septal defect, the blood always flows from higher pressure to lower pressure. So the blood is going to flow from the left to the right, so the right side chamber enlargement is going to happen. So right atrium and right ventricle are enlarged. Okay, so that's the atrial septal defect. Partial anomalous pulmonary venous return. Your pulmonary veins that are supposed to dump into the left atrium are dumping into the right side. So again, a right-sided volume overload problem. So right-sided, left to right shunt, but right chamber is enlarged, right atrium and right ventricle. Let's talk about the VSD. The blood pressure in the left ventricle is higher than the right ventricle, so the blood is going to come from the left ventricle to right ventricle. But you have to realize that the blood is coming in when the systole is happening. So left side is squeezing, the right side is squeezing. So the blood actually is going to go directly to the pulmonary arteries, and from pulmonary arteries it's going to end up in the left atrium and left ventricle. So it actually causes left atrium and left ventricular enlargement, unless it becomes complicated with pulmonary hypertension. That's not simple shunt lesion. Patent ductus arteriosus, similar physiology, blood coming from the aorta to the pulmonary artery, because pulmonary artery is at a lower pressure, and from pulmonary arteries back to the left side, left atrium and left ventricular enlargement. So for this left atrium and left ventricular enlargement. If you cannot remember them, just remember that the shunts before the tricuspid valve, which is atrial septal defect and partial anomalous pulmonary venous connections. So shunts before the tricuspid valve cause the right-sided chamber enlargement, and the shunts beyond the tricuspid valve, which is VSC and patent ductus arteriosus, they cause the left-sided chamber enlargement. Okay. So that's the basic things, and then we will go and talk about atrial septal defects. There are at least three major forms of atrial septal defect. One is the most common, is the secondum atrial septal defect, right smack in the middle. Then there is ostium primum defect, which is seen in about 15% of the patients. That is in close relation to the tricuspid and the mitral valves. Rare forms are sinus venosus defect, then coronary sinus defect, inferior sinus venosus defect. But just remember three forms: osteoprimum or the primal kind of ASD, sinus venosus ASD, and then the secondary ASD. As far as echocardiographic diagnosis of ASD is concerned, and if you're looking at the sensitivities of echocardiogram in detecting secondary ASD, if it is less than 5 millimeter, only 33% of them are detectable by surface echocardiography. 5 to 10, maybe you can detect 83% of them, and more than 10, you should be able to see them. Realize that sometimes when there is a really large ASD, you still can miss it because there is no turbulent flow across it, so it changes that. And this was compared against transmutation echocardiographies as a gold standard. So for the primal ones are typically sizable, and they are usually readily apparent by the transthoracic echocardiography in general. The sinus venosus ASD, they are in close relation to your superior vena cava, and sometimes they are really hard to figure out by surface echocardiography alone, and you should be looking at advanced imaging, either a CT scan or a transesophageal echocardiography to make that diagnosis. So, brings me another question. What if you see a patient with a right atrium and right ventricular enlargement unexplained, what is the differential diagnosis? I didn't make the audience response because I wanted to pick on some people, right? So
left to right shunt, and it could be an ASD.
ASD, okay.
Pulmonary, anomalous pulmonary.
Anomalous pulmonary venous return. Okay, 3.
Pulmonary hypertension.
Pulmonary hypertension without any septal defect. 4. Does not. Got it. 4. Just right at your right ventricular enlargement. Because it gets missed, these things get missed all the time. So. Tricuspid regurgitation, severe. Severe pulmonary cavity vegetation. Okay. So all those are differential diagnosis for RA, RV enlargement. That's actually a common consult in our clinic, is unexplained right atrium and right ventricular enlargement. So okay. So let's talk about some clinical cases. 52-year-old male presented with fatigue and syncope. Exam showed normal jugular venous pressure, RV impulse 1+, normal S1, wide and fixed split S2, ejection systolic number 2 out of 6. Actually, this has been an exam finding. I mean, this is been in the board exam. What is this ejection systolic number due to? Pulmonary outflow, okay. Sometimes you hear a mid-diastolic number. What is that from?
Tricuspid rumble.
Tricuspid rumble, okay. So, chest X-ray shows some right ventricular enlargement because the angle is more tending towards the acute, some fullness in the pulmonary vasculature. But overall, the chest X-ray is normal. So, and that's actually also a common mixed finding when the radiologists are reading the chest X-rays every 2 seconds. The ECG shows usually sometimes prolonged PR interval. Sometimes you see this slurring of the QRS abnormality in the 2-3 area, which they call as croquetage abnormality. And incomplete right ventricular branch block pattern, that's how the EKG of the atrial septal defect looks like. Left axis deviation or the normal axis, there can be normal axis and there can be left axis deviation. Normal axis usually points towards the secondary ASD, the left axis deviation points towards ostium primary ASD. Those are all the board things that they will tell you these ECGs show. And when you do the echocardiography, you want to look at the location of the defect, where it is. You want to look for the right side chamber enlargement, size and function. You want to estimate the pulmonary artery pressures. You want to see if the tricuspid valve is leaking mild, moderate, and severe, because that's going to impact how you're going to manage them. And then also realize that 10% of the atrial septal defects are associated with partial anomalous pulmonary venous. In the congenital heart disease world, it is important not to get hung up on the one defect that you are told to, but also look for the associated defects. So don't miss the sight of the forest just because you're seeing the tree. Okay? And then it helps plan the repair options. After the transthoracic echocardiography, the next step is usually a transesophageal echocardiography, and I'm showing the pictures. The pictures that you want to take is 0 and 45 and in 90 degrees, so that you can look at all the rims around the edges of the defect. And so typically any atrial septal defect more than 3.5 centimeter is usually not suitable for a percutaneous repair. The biggest device is about 38 millimeters or so. And the rim size that we're looking for is half centimeter. You need at least half centimeter ring to hang on those devices. You can also use the 3D echocardiography to plot where your whole look, how your whole looks like in all dimensions, and look at the rings. So, 44-year-old male with stroke, pay close attention. I mean, you see the slurring of the QRS axis in here also. A little bit of incomplete right ventral pattern, but the axis is different in this one. This one is a left axis deviation rather than a normal axis. So this is a classic ECG for an ostium primum AST. Okay. On the echocardiography, the way to distinguish that is that, and one of the things that was not covered in the anatomy lecture was that typically when you look at a normal heart, the tricuspid valve is a little bit more apically displaced than the mitral valve. They are not at level. But when we have a primum AST, both the mitral valves and the tricuspid valves are at the same plane. So that's how the partial AV canal, which is part of primum atrial septal defect, manifests as. So and the defect is just above the valves. Okay. So commonly, again, you have to learn the associations. I don't know why it doesn't keep on playing, but let's see. But this shows you the presence of cleft in the mitral valve. I don't know, you see that? Cleft in the center is a gap. So the primary atrial septal defect is often associated with the cleft in the mitral valve and can be associated with mitral defect. And they all come in this under this umbrella of partial AV canal defects. Okay. So primary AST impact the. What's that?
I'll go to the previous slide.
Oh, okay. Let me see. Okay. Here we go. See it now? Okay. So the whole thing is not complete. So for the primum atrial septal defect, there is no percutaneous closure because there is no valvular level where you can hang the device. So all these defects need to be surgically repaired only, and then you will fix the left acute conflict. So it's probably, this is 10% of the AST, AV valves at the same level, left mitral valve. Sometimes you can find a double orifice mitral valve. So all surgical closures if the RV environment is present. And then another patient, 15-year-old male with exercise intolerance and RV dilatation. This is a transesophageal echocardiogram, bicable view and pulled up. You can see that there is a defect over there where this is how the sinus venosus atrial septal defect presents as, and there is shunting across it. It's also important to pull up your probe further because the SVC, because the SVC which is over here, it looks elongated because it is receiving the partial anomalous pulmonary venous return from the right sided pulmonary veins usually, because sinus stenosis ASD is commonly associated with anomalous pulmonary venous connection, actually higher than the general ASD. So 10% of the ASDs are associated with partial anomalous pulmonary venous connection. An even higher number is associated with the sinus stenosis ASD. So be on a lookout for partial anomalous pulmonary venous return when you have a sinus stenosis ASD. You could use the CT scan. It's all supposed to play. So it's important. So this is your SVC in the. No, it come back again. So large defect here between the right atrium and the left atrium. That was a sinus stenosis ASD. And as we play from go back and we will play from the beginning. This is your SVC. It's receiving the pulmonary vein here, and so that's a partial anomalous pulmonary venous connection, and then there's a hole here. That's how partial sinus stenosis atrial septal defect looks like.